So two of the most exciting therapies, first of all, is a drug called APR-246, and it's a novel class of agents that is known as a P53 reactivator. So basically, when you have a P53 mutation, the sort of functional protein is kind of unfolded or misfolded and really can't do its normal function, such as inducing cell cycle arrest and apoptosis in cancer cells. And so APR-246 is actually a prodrug which is converted to MQ. And MQ can form basically cysteine bonds with the P53 protein, and this leads to a thermodynamic stabilization or sort of a shifting to a more wild type or normal conformation, thus again allowing P53 to execute its normal activities. And so we ran, a phase 1b/2 clinical trial data, which I most recently presented at ASH of 2019. And compared to azacitidine alone, both overall response rates and in particular complete remissions have been significantly improved, with about 50% of patients achieving that response, potentially higher specifically in the MDS subset. And correlating with that, the depth of remission, both in cytogenetic clearance as well as clearance of P53 mutation, have been quite profound and more so than what we would expect with azacitidine alone. And I think similarly, the GFM, led by Thomas Clouzot, presented data at EHA on their phase 2 trial, which was really a mirror trial of ours. We've worked collaboratively on this from the beginning, and really show quite comparable remission rates. In both groups having overall survival that are at least improved from what we would expect in this patient population. And these data have led to the randomized phase 3 trial of APR-246 with azacitidine versus azacitidine alone, with a primary endpoint of improvement of complete remission rate. And actually, this trial has completed accrual as of June of 2020, and we're hoping for sort of data readout on the primary endpoint by the end of the year. And if the trial is positive, this would really support the approval of this medication for P53 mutant myelodysplastic syndrome. I think in AML, we've seen comparable response rates, but less patients have been treated across studies. And importantly, we have venetoclax with azacitidine or decitabine in AML. So thinking about how combinations, whether or not triplet versus doublet in this group of patients for AML is a little bit of a separate question. The P53 group, for what it's worth, with HMA and venetoclax, has still done quite poor with potentially no improvement in overall survival, although somewhat higher response rates versus azacitidine alone.